We are live in YouTube. We are live. And we are going broadcasting live in 5, 3, 2. We are live.
All right, good afternoon, everybody. Thanks for joining us for our Miami Neurosurgery Zoomposium. Today we're going to be focusing on fetal surgery. I want to go ahead and introduce our two speakers. Dr. McCrayer will introduce our moderators. Today we have Dr. William Whitehead. He's a professor of neurosurgery at Texas Children's Hospital and Baylor College of Medicine. He's also the director of clinical outcomes and research. And then we have Dr. Michael Handler, who's the Associate Surgeon-in-Chief at Children's Hospital of Colorado, the McMurray Sebum Chair in Pediatric Neurosurgery, as well as the Chairman, Department of Neurosurgery. Thank you both.
And for moderators today, we're excited to have a great panel. We have Dr. El-Khoury, Dr. El-Baba, and Dr. Hoyer. Dr. El-Khoury is a pediatric surgeon at Nicholas Children's Hospital and director of the Pediatric Surgery Fellowship Program there. We've got Dr. El-Baba, who is the director of the Neuroscience Center of Excellence at Orlando Health Arnold Palmer Children's Hospital. And we have Dr. Hoyer, who is an endowed chair in pediatric neurosurgery at Children's Hospital of Philadelphia. So from our moderators, we'll have one pediatric surgeon and two pediatric neurosurgeons to help round out the discussion on this topic. And with that, I think we'll get started.
Okay, we have agreed that I would start, so I'm going to share my screen and see if y'all can see my slides. You have it?
Yes.
Yeah, we can see it and we can hear you perfectly, doctor.
Perfect. Okay. So I'm here to describe the University of Colorado experience and also to give some background on fetal myelomeningocele closure. I have no disclosures. We remember that the MOMS trial came about as a result of the fact that myelomeningocele affects approximately 0.5 to 1 in 1,000 pregnancies in the United States. And early on, there were animal models of fetal surgery to repair myelomeningoceles, which were thought to potentially reduce damage from exposure to amniotic fluid. Fetal surgery to repair the myelomeningocele in utero was first attempted in the early 1990s. In 1997, a hysterotomy technique was pioneered predominantly at 3 centers: Vanderbilt, Children's Hospital of Philadelphia, and UCSF. By the mid-2000s, there had been about 95 cases performed, mostly at CHOP and Vanderbilt, but some at UCSF. And that started to raise some apparent enthusiasm because of improvement in hindbrain herniation, reduction in shunting required, but some conflicting results on the effect on neuromotor function. There were major concerns that were aroused, particularly in the pediatric neurosurgery community, around the fact that these children are all born prematurely. There's an increased risk of fetal or neonatal death, and there were unknown long-term risks or benefits. Remember, this is a procedure which is potentially therefore lethal for a non-lethal condition, and that raised some very significant concerns. As a result, there was a fetal surgery conference held by the National Institute of Child Health and Human Development in July of 2000, and it was concluded that a randomized trial was essential to really assess this. It was funded in 2002. It was an unmasked randomized trial of fetal versus postnatal repair myelomeningocele with a sample size projected to be 200 to achieve statistical validity. There was central preliminary screening and assignment to a MOMS center. There were 3 MOMS centers, UCSF, CHOP, and Vanderbilt. No other center was, by agreement, would do these fetal operations, and each center agreed not to do the procedure outside of the randomized trial. The outcome evaluation was by blinded independent investigators. And that culminated in the trial concluding and being published in the New England Journal in 2011. The trial was stopped at 183 patients before the full 200 had been enrolled because the primary endpoint of death or a VP shunt at 1 year of age had been achieved with statistical validity. The second primary endpoint was going to be an assessment of the Bayley Mental Development Index and motor level at 30 months of age. The MOMS trial demonstrated significant benefit to prenatal repair with a 50% decrease in ventricular peritoneal shunts, a decrease in the incidence of Chiari-2 malformation, and claimed improved function at 30 months, though it is not certain that that has proved durable yet. There were, of course, observed fetal and neonatal complications. Intrauterine fetal demise and prematurity occurred in 30% of the fetal closure cases, and 2% children had significant brainstem dysfunction in the postnatal repair group. There was premature delivery in 46% at less than 34 weeks. And on average, the birth weight of the prenatally closed myelomeningoceles was significantly lower than the postnatal closures, as you see here, 2 kilograms versus, or 2.3 kilograms versus 3 kilograms. And there was significant respiratory distress in some 21% of the children with fetal closure. There were obstetrical complications observed with premature rupture of membranes in 46% of the fetally closed patients versus only 8% in the postnatal closures, chorioamniotic separation in 21%, oligohydramnios in 21%, pulmonary edema in the mother in 6%, placental abruption at 6%, poor hysterotomy healing in 35%, or partial or complete dehiscence of the uterus in 10% of the prenatally closed moms. This raised some real concerns. The benefits of prenatal closure became quickly noticed by the general public, and there's been increasing demand for the opportunity to access this service. There's been a dramatic increase in communication, particularly with social media. This, of course, raises significant ethical concerns about expanding the number of centers because of evangelical parents, many of whom may have unrealistic expectations of outcomes. There may be a lack of understanding of maternal and fetal risks and a willingness to assume any maternal risk on the part of the moms. And this means that there's the potential for compromised informed consent, which is a significant problem. So any program that would propose a prenatal myelomeningocele repair should happen in the context of a well-constituted fetal care center with an adequate number of operations annually to sustain the level of expertise that's necessary. That you need to have the infrastructure in place to care for maternal fetal surgical patients. One needs a post-fetal surgical ICU setting and a multidisciplinary myelomeningocele clinic to properly inform the decision-making. This means that you need experienced maternal fetal surgeons familiar with pre and post-op management and tocolysis. You need appropriate post-op surveillance, and one needs to be able to anticipate and manage the complications of maternal fetal surgery. While one needs fetal pediatric surgeons, anesthesiologists who are familiar with the techniques, neonatologists, and pediatric neurosurgeons. The essence of undertaking these procedures is formal, structured counseling in an organized way. Fetal surgery has to be presented as just one option among many. There's, of course, concern regarding hype and exaggerated perceptions regarding the MOMS trial and its results. One needs to undertake with the families a critical review of the MOMS trial, and really this takes the form of 3 phases. And this is how we approached it when we started our program. First of all, a thorough assessment of the child as to whether of the fetus as to whether criteria are met to even enroll the patient in this kind of therapy, with a full discussion of options and then formal consent. When we started our program, we undertook a formal oversight committee to take an unbiased view to make sure that our own enthusiast bias did not interfere with our judgment. So the formal structured assessment includes an ultrasound, a fetal MRI, and fetal echocardiogram to fully assess the status of the fetus. A genetic counselor is always involved, and then a team meeting with radiologists, neurosurgeon, an MFM, a fetal surgeon, and a neonatologist to assess the candidacy of the fetus. And when we were starting, we felt we must meet all of the MOMS criteria, which is to say a lesion above S1, S2, the presence of hindbrain herniation, and no obstetrical contraindication. The fetal MRI, as you see here, is a technically challenging undertaking itself because the fetus is constantly moving, and getting adequate images to demonstrate the presence of the lesion, which we can see here as a myelomeningocele, here as a more of a myeloschisis, and the same here. The fetal ultrasound similarly will demonstrate, perhaps better than the MRI, the exact level of the lesion. Here you can see the intact spinous processes and laminae in the thoracic region and the open defect through the lumbar region. When someone is a candidate, then one begins a formal structured phase 2 of the discussion of the informed consent process. And that involves an independent neonatal consultation with the parents so they fully understand the implication of prematurity in a child who may undertake this procedure. One needs an independent MFM consultation so that the mom fully understands the implications for her own pregnancy and particularly for subsequent pregnancies, meaning that mom has to be acceptable that she will not be able to labor in subsequent pregnancies. Any subsequent pregnancy would have to be delivered by cesarean section. Also important is psychosocial evaluation with social workers, and then we would proceed with oversight committee approval to proceed to do the case. And then phase 3 was a formal team meeting for the kind of consent that we typically do, walking through the process with the family so they understand at every step what's going to be happening. The oversight committee, in our case, ensured the integrity of selection and consent for each patient. And again, it was an independent neonatologist, the department chair of neurosurgery, not me, a physiatrist heading the spina bifida clinic, the chair of obstetrics, and the ethics committee chair at Children's Hospital. Now at Children's Colorado, because we're a regional referral center, we changed our protocol somewhat from MOMS. In the MOMS trial, women who undertook the procedure had to stay in the community of the hospital until after delivery. At Colorado, we kept the families in our local region for at least 2 weeks. If they could come back and had no complications within the first 2 weeks, then they would go home to their local communities where delivery would occur and subsequent neurosurgical management would be handled by the local neurosurgeons. We also instituted, with an IRB approval, a MOMS Plus protocol. The MOMS trial excluded anyone with a BMI of greater than 35. Our institutional IRB included patients up to a BMI of 40, which you'll see changed the results that we had somewhat. We had no increased incidence of problems with the higher BMI moms, however. The operation itself proves to be quite a complex process, given that there are anesthesia teams, cardiologists, maternal fetal surgeons, pediatric surgeons, neurosurgeons, and scrub support. And then this is a video that I'll show that basically describes in time lapse how the procedure is undertaken. So there's a low transverse incision that's wider in the abdomen than is typically done for a cesarean section. The linea alba is identified and opened. And you'll see here the abdomen being open. There's the preperitoneal fat. Then the peritoneum is opened, and now the uterus is starting to come into view and is visualized. The linea alba opened over quite a distance. Now the uterus is brought out. The abdominal contents are isolated from the uterus to facilitate management. Then the uterus is brought out so that the operation can be handled appropriately. You'll notice the ultrasound is brought into use to demonstrate the edge of the placenta to make sure that the placenta is not damaged in the process of doing the hysterotomy. The uterus is opened. It's critical that the uterine membranes are attached firmly to the uterus so that you don't get separation of membranes. This stapler is extremely useful. Then the fetus is brought into the exposure. That's called a level 1. The tube going in is a warming device to make sure that the temperature is maintained. That was a cocktail of fentanyl and atropine that was injected into the baby, and now with the microscope sorry about that. With the microscope in place, now we begin the dissection to isolate the placode away from the surrounding suspensory tissue and the epithelium. You can see how little elements of skin may be incorporated into the closure if one is not careful. And so it becomes important to have good visualization for closure to avoid late complications. Eventually, the placode is mobilized. In this particular case, we were able to open the dura and then separate it from the underlying fascia, and then close the dura over the placode. Then we trimmed the skin back. The dura has been closed. And now we're beginning the skin closure. In this case, the lesion was not so large as to require a patch, which sometimes is necessary. You can see the dural closure under there. The skin is closed, and then begins the process of closing the uterus itself, which is actually a critical part of the whole thing. You'll notice that the ultrasonographer, the cardiologist, is now there monitoring the baby through the entire process, looking to ensure that any problem that is developing with the fetus is managed aggressively by the anesthesia team. The hysterotomy is closed with a technique that is slightly different in our case than was in the original mom's trial. And then our team closed with application of an omental graft over the surface like this to ensure the integrity of the closure. Once again, looking to make sure that the fetus is still doing well. And then the abdomen is closed. So part of the success of this procedure requires aggressive peri-op anesthetic management with an epidural catheter for pain management, constant cardiac sonography to monitor the fetus. Inhalational agents reduce uterine tone, which is critical to be able to undertake this procedure. But on the other hand, sometimes compromises fetal cardiac function. And so there's a delicate balance that has to be played. And magnesium infusion and indomethacin to suppress uterine contractions is critical in the post-operative period. So in Colorado, in the 8 years since we did our first case, we've had referrals from a very wide area. 180, as of the end of the year, 183 mothers were referred for possible intervention, and 88 proceeded to prenatal operations. Subsequently, in the first part of this year, we've done an additional 10 or so. The mean gestational age at operation was about 24. The gestational age at operation initially was kept to 24 to 26 weeks. We were unwilling to undertake operations before the age of viability when we first got started. Now we accept earlier gestational age to 22 weeks. The mean maternal age was 28 years. The mean gestational age at repair was 24 weeks. And the mean BMI was 27.2 versus the mom's trial of 26.2. And again, that's because of our experience with our Moms Plus trial that did show no adverse impact in moms with increased BMI. The delivery, 47% delivered before 32 weeks, 53 at greater than 32 weeks, and the average gestational age in our series was 32.2 weeks versus moms with an average gestational age of 34 weeks. We had 4 extremely early deliveries within 2 weeks of the operation. 2 of them had no complications from prematurity, but we did have 2 deaths due to respiratory distress and subsequent sepsis. We also had 1 intraoperative death from persistent increased uterine tone and a placental abruption in a pre-viable, in a 23-week fetus. And we had 1 reclosure at 1 day of life from a failed alloderm patch. What we could demonstrate, as others have, is reversal of hindbrain herniation. And you can see at an MRI at 23 weeks, you can see that the posterior fossa is crowded. 2 weeks after the myelomeningocele closure in utero, you can see the posterior fossa has opened up, and that was sustained postnatally. Again, our standard protocol is an MRI at 2 weeks postnatal. We had hindbrain herniation completely resolved in 34%, improved in 41%, and unchanged in 25%. We had 3 patients who had fetal closure subsequent to delivery ended up with symptomatic Chiari brainstem dysfunction leading to Chiari decompressions. We can observe that between the MOMS trial and now, improved anesthetic techniques can reduce fetal distress. We can have longer open procedures that seem to be better tolerated, as Dr. Albaba and Vastos demonstrated in their series, and a smaller hysterotomy reduces maternal risk, as does the modified hysterotomy closure technique that was described by the group out of Colorado. It is important to note that there was a retrospective reassessment of criteria for shunting among the MOMS patients to reflect the common practice, and the data reanalyzed. And there was discovered that there was still a substantial difference in the rate of shunting between prenatal and postnatal closures, as you see here, but ventriculomegaly at greater than 15 millimeters at initial screening in the prenatal group predicted the eventual need for a shunt in some 79%. In our series in Colorado, is actually very similar to the mom's experience, that larger vents at the time of presentation predict a higher probability of need for shunting. These are a couple of photographs demonstrating the appearance of the postnatal closure. One of the complications potentially for the prenatal closure that we just usually don't see with postnatal closures is dermal inclusion cysts, as you see here on the left. On the right was an infected cyst, and you can see that the diffusion weighted image demonstrates the presence of the cyst. Often the defect is quite large, requiring the making primary closure challenging, in which case incorporating an alloderm patch facilitates the closure and leads to an equally effective result. One of the things that our place is interested in is new directions, looking at how to craft better patches. So this is a technique to acquire, as you see here in real time, a quick MR, which then allows the segmentation of different, this represents the skin defect, the placode, and the dural defect, to give a sense of how one can plan appropriately the size of patch that may be necessary. It's just one of the directions that we're moving. And we can say in conclusion that oversight and evaluation allows the inauguration of a program of prenatal myelomeningocele closure in a pre-existing fetal surgery center. The results can be comparable to mom's centers and in certain measures exceeded. And I hope I didn't go too far over my allotted time. Happy to take any questions. And I'll stop sharing my slides.
So I think what we'll do is we'll proceed ahead with Dr. Whitehead, and then we'll wait for questions at the end. How about that?
Okay.
And we started to see one question come in from the audience, so hopefully more people will type in questions as we go along, and then we can present them to the panelists along with the moderator questions after the next talk.
Can everybody hear me?
Yes.
And can you see my slides?
We can.
Great. Well, thanks, Dr. Handler, and thanks for inviting me to give this talk. I'm Bill Whitehead. I'm a pediatric neurosurgeon at Texas Children's, and I'm going to talk about our fetoscopic program for closure of myelomeningocele, and I also don't have any disclosures. And the question I'll start out with is why fetoscopy over open hysterotomy? And it's a good question because it's a heck of a lot easier to close these through an open hysterotomy from a neurosurgery standpoint. You can use your wrist, you have better visualization, your instruments work better, you can do more meticulous planes of the dissection through the tissue planes. Doing it fetoscopically, and we do a two-port method, makes it quite a bit more difficult. And I think that's the biggest problem with our technique. But you can see an intraoperative slide of what it looks like. And Dr. Handler told you, the benefits, and I think most people are aware of the benefits. But even though this procedure is good for the baby, it's really it's a maternal fetal operation, and there are significant disadvantages for the mother. The mother carries an increased risk of ruptured uterus in the current pregnancy and all future pregnancies, as Dr. Handler mentioned. They have to have a C-section at the time of delivery, and that's usually planned around 35 weeks. And then repeat C-sections for all future pregnancies, and it also puts them at risk for a rare condition called placenta precreta, which can lead to lots of complications with future pregnancies. So this open hysterotomy technique is a big problem for the moms. And I'll tell you that this program has really been driven by our maternal fetal medicine doctors. not by neurosurgery. But neurosurgeons are a big part of this procedure, and they have drugged me along. And so I'll just share with you what we've learned and what we're doing. Dr. Handler really covered this. I mean, when you do an open hysterotomy, there's more pregnancy complications. I talked about the uterine dehiscence rate, which is about a third of moms. So the question at our center when we started our program was, if we don't want to do the open hysterotomy, what are the options? One option is not to do the surgery. That's not a bad option, but because there are significant risk, and certainly a postnatal repair is the safest thing for the baby and the mom. But there are benefits, obviously, and one thing would be to try to improve the technique, and groups are working on that, and there's been some progress with many hysterotomies. But the other approach is to just find a new way to do the surgery without the hysterotomy, and that's basically vitoscopy. And we're certainly not the first to do a fetoscopic procedure for myelomeningocele. In fact, if you picked up the story before, Dr. Handler picked it up in his talk, the first few cases of myelomeningocele repair were done with a scope, and they were done by Dr. Tulipan and Dr. Brenner, who were instrumental in developing this surgery and the mom's trial. So they published a paper several years after they actually did it, but it was published in 1999, where they did 4 patients fetoscopically with 3 ports. And it was published in the American Journal of Obstetrics and Gynecology. And these are the 4 patients, and the results were pretty dismal. I don't know if you can see that X, it's kind of small, but there were 2 deaths, so 50% mortality rate. And the other 2 patients required a postnatal revision, required a shunt, and had some neurologic deficits. So pretty dismal. I'll tell you that there were some other centers that tried this. One of them was UCSF. They did 3 cases, also with terrible outcomes. And in their paper, they simply stated that fetoscopy should be stopped, and that open hysterotomy was a better way to do this technique. We started thinking about doing this in 2013, and at that time, if you looked at the literature, there were the 4 cases at Vanderbilt that I showed you. There was 3 cases at UCSF. There's a group in Germany that's led by cardiologists who've done about 60 cases, but very little reporting of their outcomes, especially the neonatal outcomes. Dr. Lapa in Brazil had reported 10 cases of a percutaneous fetoscopic approach. And Barcelona was another center that we ended up working with, who'd done about 10 cases. But at that time, when we were embarking on this, no one really had acceptable results that were anywhere near comparable to the mom's trial. There was high rates of pregnancy complications, prematurity, death, and the cesarean section rate was still pretty high, and most of these patients still required a shunt anyway. So as I said, we started working with this group in Barcelona that was led by Jose Luis Piero, who you can see there. I might be able to point him out if you don't know him. Right here, he's a pediatric surgeon who's now in Cincinnati, and they're doing this procedure. And then Elena Carreras is a maternal fetal medicine specialist. We worked with them and their team, and this is an orthopedic surgeon who helped with the closures. This is a patient. But what's interesting to me is there's no neurosurgeon in this group, which I think is always a mistake. So we worked with them and did some animal experiments, and the idea that they had was to do a percutaneous technique, insufflate the abdomen, insufflate the uterus with CO2, untether the placode, and then cover it with a patch and then glue that in place. It was called a patch and glue technique. And it was done with CO2 insufflation. And this was done on several animals in a sheep model in their lab. And Dr. Belfort, who's my partner in this And this work, he's maternal fetal medicine. He was involved in a lot of these surgeries, but you can see it here where the uterus is exposed. This is a still looking at the defect that was made in these fetal sheep, and then it's covered with a patch like that, and then this is sealant being placed over the patch, and then it's covered. The idea was we'd stop the leak, protect the nerves, prevent hydrocephalus. And they showed that it was safe in an animal model, and they proceeded to do it in humans. And I think they started this work in 2013. And this is one of those cases, and I'll just show you some slides, but this is after a single port is put in. You can see the placenta and the lesion. This is, again, in a patient in Barcelona. After the placo's untethered, they would take this collagen patch and tuck it underneath the skin edges, and then cover it with this Duraseal type glue until it was completely sealed. And that's what it looked like in surgery. And this again was all done with CO2 insufflation. And then this is what they looked like after they were born. And this was case number 3. You can see that it's really not epithelialized. A lot of the neural elements are exposed. It's another case that was born premature, not a very good result. This was the best result. This is case number 6. And this was case number 10. And between Dr. Belfort and I, we went to about 80% of these cases, and we got the opportunity to see these patients after they were born. And if you look at their overall experience of 10 cases, most of them required a shunt. Most of them required a postnatal repair. But what was interesting was the gestational age was 37.1 weeks, which was a big improvement from the mom's trial, and no hysterotomy. And so what we learned from that experience was we need to do a better repair, but the technique has maternal benefits. And so Dr. Belfort and I and other people in our team, we try to figure out a way to do this with just 2 ports. And we built this simulator using a toy doll, a kickball, and chicken skin. And this is what we actually ended up using. What's funny is we paid about $3,000 to build stuff that we thought would be a lot better, but it turned out that this was the best stuff, and it all cost about 20 bucks. Once we decapitated the baby, we would build this model and sew the chicken skin on the back, and we'd draw placoed and draw the skin edges, and then we would go into the procedure room with our stuff and we would practice. And we did this about 75 to 80 times, trying to work out a way to do this with just 2 ports. And the reason we wanted to do 2 ports was we figured if we couldn't do it, we would just open the uterus between the 2 ports. And so we make them about 6 centimeters apart. And once we figured out a way to work to do it, we went back to Barcelona and we did it on several sheep to prove that it was doable. And that's what the repair looked like after one of the repairs on a fetal sheep. And then we opened the study. It was in 2014 in the summer. And we designed the study really to answer this question. In fetal patients with myelomeningocele, can a 2-port fetoscopic closure achieve the same beneficial outcomes as open hysterotomy with lower maternal and perinatal risk? And the patients in the study had to all meet the mom's criteria, essentially. And the way we did it was pretty much everything the same as Dr. Handler showed you in that video, but once the uterus is out, instead of making a hysterotomy, we insert 2 ports. So it's done under general anesthesia with an epidural. It's a low transverse laparotomy. The uterus is exteriorized. We use ultrasound to position the fetus. We place the first trocar, and that's usually at the highest point of the uterus to give us the best view. And we're using 12 French ports, and we place them using a Seldinger technique. amniotic fluids removed, we insufflate with CO2. And then we would take a close look at the anatomy of the lesion and decide if it was doable. And in every case, we thought we could do it. But in 4 cases, we backed out and did an open hysterotomy. And that was at the beginning of the series. But anyway, at that point, we put on our second port about 6 centimeters away. And then we do the closure. And then once we finished, we'd obviously remove ports and remove the CO2 gas, and then fill the uterus with saline, and then close the abdomen. So that was the basic protocol. And the outcomes that we are looking at is the ability to achieve an adequate closure. We looked at reversal of hindbrain herniation. If there was hindbrain herniation reversal on a fetal MRI scan about 6 weeks after the procedure, the mom was a candidate for vaginal delivery. And so we followed how many patients had a successful vaginal delivery. We looked at obviously gestational age at birth, the wound status at birth, the rates of hydrocephalus and death at 1 year, and the ambulatory status at 30 months. And to do this study, we had to get approval at our IRB, but also FDA. And initially we were approved to do 5 cases. And then once we had those early results, the study got extended to the current sample size. And now the study is closed, but this is the biggest pilot study I've ever done, but we got up to 90 patients before we finally closed it, which happened this year. And in terms of the repair, we kept it simple, and we kept it too simple. But the initial repairs on the first about 30 patients were just a 2-step unified single layer closure technique, which I do not recommend, but I'll show you what we did. We would untether the placo similar to what you would do with the postnatal repair, and then we would close a unified single layer of skin and dura. And so these are some cartoons, cross sections through the lesion, basically untethering the placode. And then the closure we used horizontal or vertical mattress sutures. And we basically go through scan and try to get normal dura. The first bite was really wide, and then we come back through and try to avert the skin edges and close it. And of course, that's what it looks like in surgery. This was our first case. If you really closely inspect, you can see how thin of a repair that is. And this one had a small leak that I repaired with the stitch at the bedside, but these are really thin repairs. And our first few patients had not so great results, but I'll show you those first 15. So our mean gestational age at delivery was 34, almost 35 weeks. So pretty much on par with moms. And we had 1 patient who was less than 30 weeks. We were able to complete 12 of the 15. 2 we had to convert to open because we just couldn't complete it. And 1 we abandoned because of fetal bradycardia even before we started the procedure. These repair times are long, 2 hours. And now that we've done about 90 cases, right now our repair time is about 90 minutes on average. Although I just did one today and it took about 2.5 hours, just the neurosurgical part. We had a high rate of CSF leak, about 50%. Our reversal of hindbrain herniation rate was only 42%, subpar compared to moms. We had a high rate of hydrocephalus. About 60% of our patients ended up needing a shunt by 12 months. And no deaths, but our tethered cord rate was quite high. 42% of those first 15 have had tethered cord syndrome. And just to give you a context, in our postnatal repairs, only 10% of our postnatal repairs come back for tethered cord, and most of those are age 6 to 9. So I would say we're pretty conservative when it comes to doing a tethered cord release, and all of these 5 patients had symptoms. And so the reason I think had a lot to do with the repair. This is one of those patients, the 12-month-old had decline in lower extremity function and bladder function. And if you look at this, it's what you're seeing is you see a big lumbar cistern here. It's a very thin repair at the top. The spinal cord comes down. There's a syrinx here, but it scars really basically to the skin because there isn't that much dura, or there's nothing except for really skin over it. And as the patient grows, these scars will start to migrate up, and it kind of pulls the cord around the lamina here, and it led to a higher incidence of tethered cord. So all of those things made us change our technique in terms of the closure, and we were really influenced by Greg's paper from CHOP on myofascial flaps, which was published back in, I can't remember when, but he knows, and I'm sure he'll tell us. But they had very good results. They had a low rate of CSF leak. They had phenomenal hindbrain herniation reversal and a very low rate of hydrocephalus treatment. So we changed. We stopped using this technique, and we went to this algorithm that most of the patients I say that we've done, at least the last 3 years, have been with myofascial flaps. But this is the algorithm I sort of came up with, and the way I think about it when we're doing a repair, and it can be used for not just fetoscopic, but for open hysterotomies. And it basically divides the procedures up into to 3 steps. One is untethering the placode from the skin, 2 is closing dura, and 3 is closing skin. And so I'll go through these steps. The first step is the same as a postnatal repair. You untether the placode from the skin, and basically, if you can see between the placode and the junctional zone, well, then I just usually pick up there and make that cut, being careful not to hit the dorsal nerve roots. But if there's not a lot of visualization or room between the placode and the junctional zone, then I usually cut a little bit more lateral to that into the skin or through the zona epitheliosa, and then lift that up and then trim it back to the placode. I have not tubularized the placode. I know that's controversial. Some people do that, but I haven't. Anyway, I'll show you a diagram of what that looks like. So on the left side of the screen, this is sort of what it looks like when you have plenty of room between the placode and the junctional zone. So we'll just cut there. But if this space there is not very big, if this is zona epitheliosa and there's tissue, then I usually cut back even a little bit farther into skin, lift this up, and then trim it back so you don't hit the dorsal nerve roots, which are frequently stuck up here, at least on postnatal repair. And then the next step is closing dura, and sometimes the dura is great, but most of the time it's not. But if it is, you can do a primary dural closure like Dr. Handler showed in his video. If you get a watertight closure, that's great. You can move on to step 3, but if it's not, if there's holes or there's leaks, you can always augment with the myofascial flap. If you know in the beginning that the dura is not so great, you can just cut through dura and fascia and muscle and do these myofascial flaps. And this is what that looks like. On this side, you've got nice dura that you can close, and you may not have to take fascia and muscle from here. This on the other side of the picture, you can see those cuts through muscle and fascia, and you just take the whole tissue and fold it over. I like to lay a dura repair or a bovine collagen patch over the placode to protect it and kind of hold it down in the canal, so we don't get those scans that I showed you earlier. This kind of it protects the placode from when I sew this layer. And it may help with CSF leaks. I don't think it has anything to do with the tethering rate, but I do think it's helped with our procedure. So I'll lay a piece of dura repair over the placode and then close this layer. And then the last layer is skin. And frequently you can get the skin edges together and do a primary repair, but if the skin edges are, if the skin is lacking, then you've got to do some modified techniques. And what's been described that I know of is the skin patch, like Dr. Handler mentioned. People have described rotational flaps for open hysterotomy repairs, but with fetoscopic, you're basically, for me at least, I do these bipedicular advancement flaps with or relaxing incisions that were described by Tulipan. I'll show you what that looks like. So this is what it looks like when you have plenty of skin, but if you don't have plenty of skin and you've got to get it over your repair, you can make these cuts laterally about 3 centimeters from the junctional zone, and then mobilize the skin together. And then these are left open and they heal by secondary intention. So instead of 1 scar, you have 3 on the back. So this, let me show you what it looks like. Get it to run. This is a video. I'll start it right about here. And so there's 2 ports, and Dr. Belfort holds a channel endoscope from Storz. It has a working channel. We use 12 French ports. Let me make this play. There you go. Let me get my pointer. Okay. So in a second, you'll see the camera go through that port, and then you're looking at the lesion, and here's the placa, and this is inferior, and this up here is superior. And these are just scissors with cautery, and we're just making that opening between the placode and the junctional zone, and we're coming up the right side from inferior to superior. And now they're just washing off some blood clot, but the placode's been released, and now this is making those cuts in the fascia and the dura, basically myofascial flaps. And I usually do 1 quadrant at a time, and this is just Colorado tip Bovie cautery. And once the flaps are made, this is that dura repair patch graft that just gets laid over the placode, and you can see here why I like it. It holds that the neural elements in the canal, and then it protects them when we're stitching the myofascial flaps and the skin. And this is a 3/0 and we're just doing interrupted sutures to bring that together, and we try to get through dura all the way through muscle. And this is a Meltzer knot. It's a sliding endoscopic knot that pediatric surgeons use quite a bit, or use. It's tied outside the uterus, and then we use a knot pusher and we slide it down. And the advantage to this is there's really only tension on the flaps at the very end. So we've had much fewer tear throughs and pull outs. But each stitch takes about 10 minutes to place and tie and cut. And so it does take a while, especially when you compare it to open hysterotomy. And so these are the skin stitches going in. In this video, we're doing a mattress stitch, but since this time, we've gone to just simple stitches. And this is a monofilament. It's a 3/0 Monomax, which has a longer, it takes longer for it to deteriorate. It's an absorbable stitch. So it's like a monocryl, but it just lasts longer. And this is that same knot, modification of it, and then you just slowly bring the skin edges together. And so they're all interrupted sutures, and we usually have to place about 6 or 7 to bring the skin edges together. And that's what it looks like when we're done. And that's what the uterus looks like when we're done. And that's really the main reason for doing it this way. Let me see if I can go to the next slide. Sorry. Okay. And that's an example of one that looked really good. They don't all look like that, but that one was particularly good. And then let me just go over our results. And the study's close to accrual now, but we still are doing follow-up on the last group of patients. But I can just tell you in terms of what we've done, we do open hysterotomies for patients who don't want to be in the study. But if you just look at and we've done 44 since 2011 after the MOMS trial was published. But last year we didn't do any open. They were all fetoscopic. And yeah, so last year we did 15 fetoscopic procedures for a total of 85, and I think we're at 90 now. And again, we just closed the study. And so I can give you our results up until December of 2020. So this table shows this row. Let me show my laser pointer. Sorry, okay. So these are all of our fetoscopic cases, the early ones and the late ones, and it's our first 85 cases. So this column is the key column. And then this is since we improved our closure technique to that myofascial flap, or we call it a 3-layer closure because of the patch. So that's the second half of the series. It's a subgroup. These are our open cases, and then we compare it to MOMS, which probably isn't fair anymore because that's 10 years old, more than 10 years old. But what I'll show you is we usually do the surgery around 25 weeks, but we do like 24, 25 weeks in general. We had one prenatal death, and I'll go over that with you in a second. But if you look at our gestational age at delivery, the thing that stands out is our mean gestational age is 37 weeks. And that's been basically through the whole study. If you just look at the last half, we're at 37.3 weeks, which is an improvement. And in our open hysterotomies, we're at 35 weeks, which I think is pretty standard, or we're in that range. But the gestational ages are longer. We're having fewer complications of pregnancy with things like premature rupture of membranes, a rate of about 30%, which is down compared to the MOMS trial. Preterm deliveries they still happen, but our rate of being born less than 30 weeks is about 5%. So we've had 3. And when we do open hysterotomy, it's higher. It's about 10%, and in the MOMS trial it was 13%. So I also think this is an improvement. Big improvement is the rates of vaginal delivery are 50%. So half the women are able to have a vaginal delivery after this procedure, and half of them have, and that's been through the whole study, which is a big improvement for maternal health, and it's beneficial for the baby. Because our gestational ages are longer, our birth weights are better, bigger. They're about 3 kilos on average. Our treatment for hydrocephalus rate for the whole group, and these are only kids who have had a year of follow-up, is 36%. And if you just look at the last half of the series, it's 30%. And so once we went to the myofascial flaps, we haven't had a CSF leak. Our hindbrain herniation reversal rate is over 95%. So that really helped. The last outcome I'll show you is walking status. So these will just be the patients who have 30 months of follow-up, and so there's about 43 in the group. And these results are pretty much on par with the MOMS trial. So walking in any form is 81%. Walking independently, no braces, no walker, not just 10 spaces, but basically a community ambulator was 10 patients. 11 patients are walking with orthotics, 14 patients are walking with devices, meaning crutches or reverse walkers, and 8 are wheelchair dependent. So pretty much on par, I would say, with the MOMS trial. But when it goes badly, it really goes badly. I'll show you those cases. We had 3 cases of extreme prematurity, so less than 30 weeks. So we did the surgery at 25 weeks. The patient was delivered at 26 weeks, had a very precipitous delivery in the hospital. On post-op day 3, that patient had tons of complications of prematurity, including respiratory distress, bronchopulmonary dysplasia, retinopathy of prematurity. That patient required a G-tube with trach. I had to redo the repair because it basically fell apart in the NICU. Hydrocephalus, yes. Non-ambulatory, yes. And a hospitalization of 253 days. The second one was a surgery we did at 25 weeks. We had to deliver intraoperatively because of bradycardia, and that patient had complications of pregnancy, developed hydrocephalus, non-ambulatory, and was in the hospital for 141 days. And then the third case, the surgery was at 24 weeks, delivered at 29. Fortunately, that patient did pretty well with no hydrocephalus, is walking independently, and was in the hospital for 76 days. And this was our death. It was a 22-year-old woman who had a BMI between 35 and 40. We did surgery at 24 weeks. We did a 3-layer closure. At about 3 weeks later, the membrane separated more than 50%. We admit those patients to the hospital when there's significant membrane separation. On the initial assessment, the baby was healthy, doing well, but the next day, when the ultrasound was repeated, the baby had passed away, and I'm sure it was due to the membrane separation and probably trouble with the placenta. The umbilical cord was wrapped around the baby's ankle, and there's a possibility there was some sort of cord accident, but that was our one death in the series. So if I just go back to our original question for this pilot study, I think our answer is going to be yes. Of course, we'll finish the analysis in a year, but we are seeing improvements in gestational age. We are seeing vaginal deliveries. I do think our results now are on par with what people are getting or got in the MOMS trial and are getting currently. I do think we need to still improve this technique because it's quite difficult. We need better instruments, better visualization. And I think as other centers start doing this, that will speed up the process. There is a registry in place that's funded by the Fetal Medicine Foundation. It's an international registry on REDCap that we organized, and several centers have put in patients. I think there's about 250 patients in there now. It's voluntary, but if you decide to start doing this, we should talk, and it would be good to get your team in the registry. I always tell families that fetal surgery is not a cure. There's still comorbidities that patients will have, as Dr. Handler mentioned. And in the interest of time, I'm going to stop there. These are people on the team at Texas Children's who are instrumental in this work, and I'll take questions. Thank you.
Well, that was incredible, two talks for us. So I'll go ahead and open up the floor to Dr. Albaba, Dr. Huer, to see what their comments are and their experiences.
Greg, you want to go ahead?
Sure. I love listening to the last two speakers speak, in part because they're what you would want in neurosurgery, ethical, skilled surgeons, and particularly Dr. Whitehead in his knowledge of being able to follow the statistics. Because I think what is most, and I love listening to him because he's an honest broker who tells you, and has the data on his own patients. I feel frustration when I go to give talks from centers where they see sometimes the disasters. I particularly saw this in Europe, where the group from Germany would operate and then not follow up on those kids. And so, I'd like to hear what Dr. Whitehead, Dr. Handler think about both the short and long-term outcomes and how important that is to know your center's outcomes and to follow these kids for 10, 15, 20 years.
I can, but I mean, I just like you said, Greg, I think it's key, right? I mean, we're collecting, I didn't mention, but we collect that on the neurodevelopmental outcomes at 3 years and 5 years. And so those have to still be looked at and analyzed. But I think the key to what you said, Greg, is neurosurgeons have to be involved, because if a neurosurgeon's not part of the team, the maternal fetal medicine specialist and the pediatric neurosurgeons, the pediatric surgeons, they don't follow these patients in spina bifida clinic like we do. And so it's a key part of the team. And if you're not getting those results, like in Germany, and I would say even in Barcelona, it's because neurosurgeons aren't involved.
I would concur. I mean, these procedures can't happen in isolation. It has to be part of a continuum of care of kids with myelomeningocele, and you have to follow them. And that's, I mean, it is a dilemma when patients travel great distances to establish protocols to allow you to follow these patients and get the late results. That takes a lot of work, and it takes a commitment on the part of the centers that are undertaking this to actually track down those patients and follow them.
On that note, and you both sort of hinted at this a bit, what is your thought in terms of the retethering and, you know, the concern for earlier retethering and what effect that may have on the function of these kids going forward? And do you think that's something where the more the technique perfects, the less it's going to be an issue? Or do you think that's just inherent in the fact that it is more difficult, you're dealing with a smaller patient when you're doing this as a fetal surgery?
Well, I personally, Bill and I had a conversation on Saturday afternoon about this, because the fact of the matter is that I think that we as a group of neurosurgeons are not really clear on what actually constitutes cord retethering in the first place, and what would be an acceptable way to assess that and to determine when to intervene. I mean, I think to me, that's where I have the biggest concern, particularly when kids are being cared for by anybody other than me. Then are my criteria the same as that of the neurosurgeon in the local community who decides what to do? I mean, in the case of an identified epidermoid or dermoid, then it's easy, right? Because you can see something's growing in there. But even there, you know, the criteria for intervention are not well established, right? I mean, is the fact of seeing a dermoid develop grounds to justify another operative intervention if it's not causing any trouble? I don't know the answer, you know, but I think that these are the kinds of questions that we as a community have to address and then work out among ourselves.
So I was just looking at my last sort of 60, I think 65 untetherings in the fetal kids, and you know, it can be safely done. One thing that I think is highlighted by the untetherings is the initial surgery affects your life with that patient, and I think Dr. Whitehead would agree to this. The untethering in a patient who was closed in a little, not as quite a good way, let's say, just to be, you know, politically correct, is much harder when there's epithelialization of the placode. I remember Lee Sutton told me early on he had a case where he just closed skin because they didn't know any better, and the skin was directly growing into the spinal cord. So, you know, I think Dr. Whitehead should be applauded. You guys don't realize how incredibly hard that fetoscopic closure was. It looks easy on videos, but, you know, closing those dural layers, untethering of a badly closed is really, really hard. And so I think what these guys make look easy is you set that patient on a path with that first closure for everything, how well the hindbrain herniation goes away, how easy the untethering is, how much muscle is there, as Dr. Whitehead pointed out. Those things are really important. So it doesn't happen in isolation. And that initial outcome that some of the centers without neurosurgeons pointed out, look, baby born, they were moving their legs. And then when you talk to the surgeons in Germany, they had to do these horrible unthetherings. So.
Yeah, I completely agree. I mean, I showed you those examples of our single layer repairs, and I think that repair is the cause of tethering. But I do think if you get a dural closure or myofascial closure, you'll see it much less. And you know, I think when centers start reporting their tailored cord rates for fetal surgeries, it has to be put in context of what their postnatal closure rates are, because of what Dr. Handler said, because there's a lot of variability, just like in the treatment of hydrocephalus.
Wow, I think that's amazing, amazing conversation. And thank you guys for including me in this. But it's very clear now, I think, from Greg's work and now with what Dr. Whitehead presented, is that the layered closure is the way to go, and possibly watertight closure is the way to go. If you combine that with the fetoscopic approach, in a sense that ultimately the fetoscopic approach is better for the mom, have you guys come up with the criteria, even in Texas Children or in Colorado, where if you cannot achieve the watertight multi-layer closure in the fetoscopic, would you do an open at that point, or there's other ways to come about that? And I know the group in Cincinnati is trying 3-port technique, which it seems to be cutting on the operative time significantly. Have that been considered at all instead of the 2-port technique? Which seems like it's amazing how you guys can communicate like almost like a mind, like your minds are talking with the 2 ports, the person who's holding the camera and the person who's executing on the instruments.
Yeah, I think that's the biggest problem with what we're doing. It's going to be hard to get, it's hard to reproduce. And Dr. Belfort is pretty driven to try to get this done. And so we did a lot of simulation together, and now we've done a lot of cases together. And it is a lot easier now because we've done over 100 cases. But most people who come and watch want to do 3 ports, and that's what a lot of the other centers that have started to do it are doing, and that makes sense. We've tried 3 ports. It's not faster for us. And Mike's Belfort's concern is, any additional trauma to the membranes will influence the results. So even though it may be faster, we think that if another center starts doing 3 ports and they get equivalent results, then we'll consider switching. But we're on this track of 2 ports, externalizing the uterus. And the thing that externalizing the uterus does is it allows us to tackle the membranes before we put the ports in. And I think that's what helps with decreasing these pregnancy complications. There's groups that are doing this through a totally percutaneous approach, where they just put the ports in through the abdominal skin, through the peritoneal cavity, and then into the uterus. And those teams are having higher rates of membrane separation, ruptured membranes, and prematurity. I will say to the first thing you asked about whether or not, if we don't think we get a watertight closure, do we switch to open? And that was the way the protocol was written. And we had 4 cases where we had to do that early on, but we haven't had to switch in probably the last 50 cases. The last 50 cases, we've been able to achieve a good repair. Probably watertight, maybe not totally watertight, but good enough where we didn't think we'd get much improvement if we opened. Yeah.
Mike and Bill, great talks as always. As we all agree, we already established a track record of safety now for either the open or fetoscopic technique. I am in favor of pediatric neurosurgeons working with fetal surgery programs anywhere in the world to not only to follow the patients long-term, but also take the lead in defining what is the right technique for that center. I personally have been fortunate to work with colleagues in St. Louis and in Orlando, close to 100 cases so far. And I can tell you it's chemistry. It's working as a team and tackling intraoperative challenges and postoperative care and working as a team and getting the best outcomes possible. I really applaud Bill for the great developments. I remember when he started talking about fetoscopic closure a few years ago, how things evolved beautifully since then. A lot of hard work and animal models, and until you get what you're achieving right now. I'm a firm believer in achieving watertight closure in every case. I do believe without achieving a watertight closure, as you demonstrated in your data, will not achieve the hindbrain herniation as well as the hydrocephalus treatment rates. You'll not achieve what you want unless we achieve a watertight closure. And although our program and myself have been in favor of a 3-layer closure, tubularization, or neuralization of the neuralization of the placode, followed by dural closure or fascia closure, followed by skin closure. Although I've been a believer in this technique, at the end of the day, this, in my opinion, leads long-term untethered cord outcomes, but 2 or 3-layer closure will not change the rates of hindbrain herniation reversal or treatment of hydrocephalus as long as we achieve a watertight closure. There's no question the only way we move forward is by following our outcomes long-term. That's why registries are extremely important, and the North American Fetal Therapy Network, the NAFNET MMC surgery registry hosted by Greg Steen at CHOP. This registry is the only way for us right now to track our outcomes long-term. And I'm glad there's a separate registry also in parallel or moving forward for the fetoscopic closure.
I mean, just as another plug, the other registry that is now collecting whether the closure was done fetally or postnatally and whether it was open or fetoscopic, I mean, they're limited in how much they can, is the CDC's spina bifida registry is now collecting that data long-term. You see how sort of struggling it is to get all the data, because apparently we can just say collect more data, but then I watch these people inputting this stuff. Holy shit, that's a lot of work.
My question to Bill is, you may agree with me or may disagree that untethering a patient with both clinical and radiographic tethering, ones who actually need surgery, untethering a patient who had fetoscopic repair can be way more challenging and difficult than open repair. So this is the first question to you. Have you noticed any changes or any differences in or the way you perform untethering when the patient had previous fetoscopy or postnat or open repair?
When we did the single layered repair, the untetherings were a nightmare. And I think I've done every one of those, and they still keep popping up. I have not had to untether a patient who had a 3-layer repair with myofascial flaps and the patch. Although there's one patient I know of who's got an epidermoid who's up in Salt Lake. And that epidermal, it's asymptomatic, but the epidermoid's growing, and I think Doug Brockmeyer is taking care of that kid, and I think they'll get an untethering. So it'll be interesting to see what he finds. But I will say too that, I think neuralizing the placode or tubularizing the placode or rolling the cannoli, as Dr. Oakes has put it, I wasn't trained to do that. And so I don't do it on my postnatal repairs, at least routinely. Sometimes I'll do it just if it's a wide placode and it's getting hard to close the dura and I need to just decrease some of the mass. I don't think leaving it open increases your risk of tethering. I do think leaving it open makes an untethering surgery harder.
Thank you. And the other question for you is, as there's a healthy controversy right now between fetoscopy and open surgery. My personal opinion is that fetoscopy is the future, but it requires significant degree of training and collaboration to have the same track record of safety as we have right now with the open fetal surgery. It can be 10 years for me or other programs where fetoscopy is the way we're going to go. My question to you is, for new programs with no experience in fetal surgery for spina bifida, is fetoscopy the way to go to be their first case? In other hand, the other question is what are the criteria for a program to be ready to go fetoscopy if they haven't had any experience with doing a single open case? The best way I can describe it is, will you let someone operate on your appendix to do laparoscopic appendectomy if they've never done an open appendix case?
Yeah.
I've seen this in Europe. I've seen it in some places in the US where there's so much excitement about fetoscopy, they want to start doing it. Obviously, they go and they train and they observe, and they would have people with them in the OR to support them with experience. But at the same time, what is the backup plan if things don't go well and you have to convert to open and your program have never done a single case? What is your thought about it?
So I think you have to be skilled at open hysterotomy and that repair first. I think that helps. It certainly helped me. I also think, fetal centers, you don't start by doing myelomeningocele. As you build your fetal center, you do, other fetal intervention cases, get skilled at that, and then build. And I think the myeloclosures are one of the most difficult pieces of it, and it shouldn't be the first thing. It's usually the last thing after you establish the fetal center with collaboration between anesthesia, maternal fetal medicine, pediatric surgery, radiology. I mean, there's lots of pieces. And the reason we have a program is because our fetal center was established and doing open hysterotomies and exit procedures, and most of the interventions that are proven for fetal medicine when MOMS came out. And so when the MOMS trial came out, we moved immediately to try to get the resources to do that. But it takes a lot of support and lots of different disciplines to do it. But I do think you should be good at open hysterotomy for repair of myelomeningocele before you start doing fetoscopy.
Thank you.
Yeah, I know. I think that's very, very, very important. And I think that was part of Dr. Handler's presentation to some extent, how you need an established fetal center to some degree to achieve the best possible outcome. And I want Dr. Handler to comment a little bit on the oversight committee that they have, probably Texas Children also has, just to kind of enlighten the audience a little bit about what's the importance of that oversight. But I do agree with Dr. Baba is that, or I kind of want to elaborate a little bit on the question for even, CHOP now, which is, Greg maybe can enlighten us a little bit where they are with their fetoscopic endeavors. But can we stand on the shoulders of the people who already did the work? In a sense, let's go back to the appendectomy model. When I went into my pediatric surgery fellowship, I actually started doing pediatric appendectomy laparoscopically immediately, with the caveat that the people who taught me knew how to do open appendectomy. There's a problem. So maybe that's something warrants some discussion, in a sense, who's supporting you, who's backing you up, who's teaching you, will make the difference in where's your launching point of the technique, given if we prove that fetoscopic is better for the mom 100% and we can achieve the same results. So probably it's not ethical to offer them something that may not be as good for both moms and baby. And those are big words probably, but I would like to hear you guys comment on that.
So what I've been struggling with is the notion of that of course, fetoscopic interventions, minimally invasive interventions are always better than non-minimally invasive intervention. Doesn't matter whether you're doing a knee or an appendectomy, if you know how to do it and can do it well. The problem is when you've got a well-honed team that does very well what they do now, how do you evolve your practice? How does surgery innovate? It takes a huge amount of commitment. And I mean, face it, the problem for all of us, except Bill, is that we're not practiced fetoscopic surgeons. And the key point to his presentation was how many sheep did they do first, right? You said something like 90 sheep.
Simulations. It was somewhere between 75 and 80 simulations, and we probably did about 15 sheep. But
yeah, the point is that it takes a huge amount of time and commitment to actually take those steps. I mean, I'll be honest with you, we have been thinking about doing that in Colorado. But the question is, who's got the time? How do you make the time? How do you take those steps forward? I mean, I showed you how we're modeling, how do you model the size of the defect? Because, I mean, really, conceptually, if you could mobilize the placode, get some kind of closure with some kind of patch that really would work, it'd be a lot more efficient than trying to mobilize the skin at 10 minutes per stitch, right? I mean, ultimately, if you had the right kind of biomaterials, you could just go in with a fetoscope and go bam, 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 which is the concept all along. We're just not there yet. It's going to take a lot of work still. But that's really what it's got to be about. But I would concur, you got to start with what you do well. And what you have to, and the most critical aspect of fetal myelo closure is the MFMs, right? That's the most important thing, because you're not going to get through this safely unless you have a competent team of MFMs who can do the tocolysis that is necessary, because you're assaulting the uterus. And so they have to really be comfortable figuring out how to manage this.
Well, I agree.
We have a couple audience questions too. I want to make sure we go ahead and ask as well. The first is actually for Dr. Handler. They were asking what suture you use for the placode, the dura, and the skin. Presumably the question is, how does that differ from what you use postnatally versus what you use?
A lot smaller. So for the dura and the placode, if we were to try to close the placode, 8-0 vicryl on the dura. Be really careful with the 8-0 vicryl. The first one we did, the auto suction device sucked up the needle. It was really very, very disturbing because the needle is exceedingly small. And the idea of trying to find that in a pregnant abdomen is really, really a problem. We looked in the filter for the auto suction device to clear saline off of the field and found it in the filter, fortunately. So 8-0 vicryl and then 5-0 PDS is what we use on the skin.
And another question we had was whether, in addition to retethering weight, which we discussed, is there a thought that dermoids and epidermoids are higher in fetal cases than in postnatal closure, or do we?
I think they're higher. Yeah, I mean, I honestly don't recall a dermoid or epidermoid in a postnatal closure. I just don't remember it. Maybe that's because somebody else took care of all my complications, but I don't know.
We get scans at 1 year on the prenatals and the postnatals to look for that, and the rates are higher. They're like 10 to 15% in our fetal cases and less than 5% in our postnatal cases.
And the second part of the person's question, do you think that is able to be prevented with better techniques? Do you think that'll decrease in the future?
Sure. I mean, we're always going to get better. I mean, the point is that this is why you have to be well practiced, and you need people who do this again and again and again, right? It's like everything else. It's like aneurysm surgery, right? If you do 2 aneurysms a year, you're not going to be as good as if you do 100, whether it's, that's, I mean, so that gets to another question of how many centers should be doing this at all in the country, right? Which is something none of us wants to really talk about, but probably needs to be at a broad policy level thought through. Right? And I don't have an answer. I mean, obviously we all want to be doing it. The question is, are you going to make sure that you're in a center that is able to sustain adequate volumes, right, in order to maintain your competence.
Absolutely. Greg, I was going to ask you, where are you guys at, kind of piggybacking on what Fuad was asking about fetoscopic and your kind of where you guys are there as being one of the initial people within the MOMS trial?
Yeah, I agree with some of the comments that have already been said. I think there's some significant advantage to it, particularly with the advances Dr. Whitehead made. There's still a large group of centers that are doing it in sort of the slip shot kind of way, just putting something down and closing, and you can get away with that in a fetus because it's a low pressure system, and so you might be able to convert someone to basically a minor skin covered defect. But you need, I think that's just getting away with it, and if you look at long-term outcomes, it's not going to be good. I'd love to have a patch that was like multi-layered and created dura and muscle. I mean, that's the future. But it's the current patches are basically just a piece of gel foam over there. Sometimes it has to be a little bit better than that. So we'll move that way. We have a pretty large person in charge of our fetal center, Dr. Hedzik, who he has some super ownership on this field and really holds it like a baby, no pun intended, and really wants to make sure that everyone's doing it in the right way. I think people like Dr. Whitehead, Dr. Handler, Dr. Elbala have an advantage in that I agree that the neurosurgery part is what we do, what we were trained to do. It's a little bit smaller, but it's that postoperative mom care. And then Dr. I just saw that slide that you had with your post care. You have that awesome spina bifida group there. How much of our outcomes are dependent upon that incredible care? And the question I was going to ask too is, how do we have to integrate that they know what the care is afterwards? Because I know my fetal kids have different problems. Some of them are enhanced, some of them aren't. So sorry to come around from your question, but I think we're all going to incorporate that, remembering that none of these are cures, and we're always trying to get better surgically, and that we're often with every different outcome trading off something for something else, and moving the field forward. Really remember that fetal surgery, how awesome it is in one respect is that it's led us to think about these kids in a more scientific manner and moving the field forward, which we didn't do before MOMS trial. We didn't have these long-term outcomes. So I think that's super exciting too.
These are really great talks, and thank you so much, Dr. Whitehead and Dr. Handler, for giving these two really great presentations. I guess my question is for you guys, what proportion of your patients, your myelomeningocele patients, are repaired prenatally versus postnatally? And of the postnatal repairs, what proportion of those are because they weren't candidates for prenatal repair, and what proportion of patients choose not to go through with prenatal repair?
So at our place, it's about, it's a little bit skewed because people come from out of town. And so the people who come from out of town usually come because they want fetal surgery. So if you just look at everyone, it's about it's 2/3 who get fetal surgery, 1/3 who do.
Yeah, once they meet criteria. I mean, a significant number will turn out not to meet criteria. But this actually gets to the importance of the integrity of the prenatal counseling, right? That what you need is you need a counseling group that will convince a significant number of people to get on a plane and go home again without the operation, right? Because that means that you're actually presenting the data honestly, correctly, and we always feel bad when this, mom came from San Francisco to Denver to get the operation. And by the time the second phase counseling was done, her hair had turned white and she, no offense, Bill, and she got back on the plane and went home. You know? So
But I think
that's an important part of it.
For me, it's about 30 patients a year do prenatal, 30 to 40, and then I have an even number. I get about 30 to 40 who come to get postnatal. And the reason they do postnatal more often, other than what Dr. Handler said, that they don't qualify, but the more common thing is that they might have a very low lesion that's, let's say, you know, L5, and they think, well, I'm going to have 4 more children. We get a lot of patients from New York who are planning to have 5, 6, 7, 8 children for religious reasons. And they think 8 C-sections, probably not a great idea. So maybe an option that Dr. Whitehead, you know, would be a better option for that particular patient, for instance. So that's why it's important, as Dr. Handler said, to have everyone in that room, not just the neurosurgeon, because the MFM is thinking about that woman's maternal health. The social worker is thinking about that person's social situation. They have to care for other children. You know, I agree with Dr. Handler. They should know what that patient's benefit is, shunt, walking, not walking. They should know what their risks are in that patient, and you really need to do it safely. So my patients, it's usually because it's a lower lesion or they're planning to have more kids. Not typically for the hydrocephalus reasons that their vents are big. That's less common. And the most reason they aren't candidates are that they have another abnormality, or the mom has a healthcare problem that precludes her from being in.
Mm-hmm.
We have to remember all the patients come to us from OBs and MFMs, and if you read carefully the fine print of the 2017 guidelines or recommendations from ACOG, American College of Obstetrics and Gynecology, they focus on counseling in non-directed fashion about all treatment options, including fetus surgery. The counseling is extremely important.
Mm-hmm.
I think this is a great note to wrap up the discussion, because we've gone longer than we had planned, but that's because it's been great talks and great moderator discussion as well. I think one of the things that struck me in this discussion is this is obviously still somewhat of a controversial subject, despite the fact that it's one of the few things we have a great randomized controlled trial for in pediatric neurosurgery. And I think the level of discussion today and the points brought about where the field is moving and the importance of really appropriately counseling our families has been a really great and thought-provoking discussion, and hopefully one we will continue. There's a YouTube link posted if anyone wants to share it with any of their colleagues or trainees, and we'll try to send the video out in the coming days as well. So I'd just like to thank again our speakers and our panelists for the great discussion tonight.
Thank you very much, guys. I really appreciate the discussion and the time you guys spent with us tonight.
The points brought about where the field is moving and the importance of really appropriately counseling.
Thanks.
Okay, thanks for having us.
Thank you.
Thank you, guys.
You.
Thank you
Have
for
a great
having me.
night.
Bye.
Have a good night.
Yeah, good to see everyone. Bye.